On behalf of iScience, I'd like to thank everyone for taking time out of their busy schedules to attend this conference call to learn more about canaloplasty. My name is Rick Venzel. I'm the Vice President of Sales, and I'll be hosting this call. As I indicated, I've muted all the lines to cut down on the background noise and hopefully make for a clearer call for all. At the appropriate time, I'll let you know how to unmute your lines and ask questions. I am pleased to say that canaloplasty is the fastest growing minimally invasive procedure for glaucoma. Over 15,000 procedures have been performed to date, with about 10,000 of those in the U.S. alone. My apologies to those of you on the call that are sitting in our training backlog, but the demand for training has overwhelmed our training resources, and it's taking us anywhere between 60 to 90 days to work new surgeons into the calendar. We are trying to address this need by hiring additional training staff, but it will take a while for us to get caught back up because you will find once you get around to being trained, we do have a world-class clinical specialist group, and it takes time to get those guys up to that level of competency. So please bear with us, and we'll get to you as soon as we can. Tonight, we will get the perspective from both a glaucoma specialist, Dr. Howard Barnebey, and a general ophthalmologist, Dr. David Richardson, on why they added canaloplasty to their practices and what it has meant to both of them, and equally important, what it has meant to their patients. Dr. Barnebey, for those of you who don't know him, he is in private practice in Seattle, Washington. And to date, he has done over about 375 cases of CP on everything from simple primary surgery to patients that have failed other surgical procedures. Dr. Richardson is out of the San Gabriel area in California and is closing in on doing his 100th case currently. The interesting thing Dr. Richardson will tell you is why he's offering canaloplasty when he had not really performed any glaucoma surgery in over 10 years. Dr. Richardson does a lot of his cases combined at time of phaco to reduce or in most cases eliminate the need for drops. Dr. Barnebey and Dr. Richardson, if you would both hit #6 to unmute your lines and join in on the call, that would be great.
Okay, should already be done.
Great. Dr. Richardson, I hear you. Dr. Barnebey, are you there?
Can you hear me, Rick?
Yeah, I can hear you, Howard.
Okay, so I am muted.
All right, great. Dr. Barnebey, maybe if you could speak up a little louder. You weren't quite as clear as Dr. Richardson. But if I could get you to start off first and basically just let everyone know why you added canaloplasty to your surgical armamentarium and a little bit about what it's meant to both you and your patients. I think that would give them a good place to start from.
Okay, I'm happy to do that. Is this a better volume for everybody to hear me?
Yeah, that's pretty good, Howard. A little louder would be a little bit better.
Okay, I'll try the best I can. First, it's a little bit of introduction. As Rick mentioned, my training is in glaucoma, and I have had an academic private practice for the past 25 years. And like most ophthalmologists, I was trained with trabeculectomy and also tube shunts, and found that overall they worked pretty well. But the disappointment for me was really threefold. One, I could do what I consider to be a classic textbook trabeculectomy, and I wouldn't be 100% sure what the patient would look like on the first post-operative day. Second, we can have trabeculectomies which were done very well, and they seem to have limited lifespan. And then finally, there are those people who had significant problems after a trabeculectomy. And I think it was highlighted in a number of studies, but the most recent one was the tube versus trab study that Getty published. And for those people who were in the trab group, almost 60% of people had serious complications or needed a reoperation. And that number really floored me, and it drove home the point that maybe there are other operations which are better. And perhaps 10 years ago, maybe a little bit longer, I was involved with non-invasive procedures, and the one that was the most popular at the time was the viscocannulostomy. And while it worked in some patients, it wasn't quite as successful. And it wasn't until we were able to have a better understanding of how to do the dissection and the introduction of a means of completely opening up Schlemm's canal and placing a stent, did I find that this particular type of surgery would fit well in my hands. And it's fit well not only based on the literature experience, which supports it, but my patients are able to have a quicker recovery. I have a much more predictable post-operative course. And our results, while they're not quite as good as some trabeculectomies, we're finding that we're getting pressures consistently in the 13 millimeter range a year out on no medication. So the difference and the question of a non-invasive procedure not being as good as a invasive one or trabeculectomy, in my hands, really hasn't played out. So from my point of view, this particular procedure filled a lot of gaps that I was missing with other procedures. And that's why I was attracted and got involved in canaloplasty. And it's evolved to the point where in the majority of my patients, it's my first go-to surgical procedure for glaucoma. And I'll just stop at that point and kind of lateral over to David and learn his perspective on how he got involved.
Okay. Well, I certainly have a different perspective, though I've come to the same conclusion. I have been in practice for a little over 10 years, and as a resident, I performed a few trabs and a few tubes, and really, honestly, didn't feel really very comfortable with the post-operative course. It was just too unpredictable. Didn't feel that I had as much guidance as I needed, and it just wasn't something that I really enjoyed or felt would add to my practice. As far as trabs go, the unpredictability early on of the post-operative course was just something that I was not interested in participating in. So I actually told myself after residency that I wasn't going to do another trab. And that's exactly what I did. I did not perform another trab for 10 years after graduating from residency, and still haven't performed a trab. I'm in an area, Los Angeles here, where there are a number of glaucoma specialists. And so that's never really been an issue, especially since Zalatan had just come out during my residency, and the effect of Zalatan on the number of trabs that needed to be performed was similar to the effect of the recent economic downturn on LASIK. So there was really no desperate need to perform glaucoma surgery with a number of the glaucoma specialists in the area. But over time, the patients that I had who did need to go on to surgery, some of them had surgery in one eye, and due to whatever the response was in that eye, whether it was worsening dry eye, which is very bad here in Southern California, almost everybody has some ocular surface disease, or they just weren't happy with the vision, or had hypotony maculopathy, or whatever it was, they just really weren't interested in having trabeculectomy on the second eye. They even had a couple of patients tell me that they would rather just let the glaucoma run its course and go blind than put themselves through a trab on the second eye. So I became interested in looking at some of the other options that were available. And, my partner at the time, whose father was Richard Kratz, who had participated with viscocanalostomy and was excited by that. He actually introduced me to canaloplasty through Adam, and despite the fact that Adam had previously worked for conductive keratoplasty, I decided to give it a chance. And my very first patient for canaloplasty was a patient who was on 10 drops a day, severe ocular surface disease, not well controlled, had seen 2 glaucoma specialists and just was not interested in having trabeculectomy or a tube. And she came back to me and she said, I'm not going to have these surgeries done. Is there anything that you can do? I told her at the time that there was this new surgery that I was considering offering, which seemed to have a better risk profile, but similar IOP lowering results. And I told her, I said, I've never done this before. She wanted me to do it, and I know a number of you on the line there must have patients who you've developed this sense of trust with, and they would prefer you to do the surgery on them. And if you don't offer TRABs or you're not happy with TRABs, this is a nice thing to offer. But in any case, the amazing thing about this, my very first patient, after a relatively rocky postoperative course as expected from a procedure that I was just learning, she now is one of my absolute happiest patients. I get a hug from her every single time she comes into my office. The reduction from 10 drops a day to 0 has just made a huge positive impact on her life. Her vision's actually better because her ocular surface disease has improved. And, I can tell you that I don't have a single patient who was sent out for TRAB who has come back and hugged me saying, that's such a wonderful thing that you did sending me out for this TRAB. And of those in the area that I talk to who do TRABs, they also are very hug deficient. I now have a good dozen canaloplasty patients who give me hugs when they see me. It's actually, in some ways more encouraging than cataract surgery because, as we know, our cataract surgery patients now have such ridiculously high demands with what they hear out there that, many will come back 2025 post-op day 1 and wonder why it's still a little hazy. With canaloplasty, it's just been a real wonderful experience for me and my patients.
Thanks, David. I appreciate that. Howard, back to you. As a glaucoma specialist, we all know that glaucoma can be a lifelong disease, and treating it, we need to be careful on what we do when. How has that kind of entered into your thought processes as it relates to CP, as far as options that it gives to patients?
Well, I think if you have another tier of surgery that is, one can say it's less invasive, then it perhaps makes surgery a more attractive option than it was before. Now, one of the negatives that has always been hammered on us is that if we do any type of trabeculectomy or if we make a scleral flap, we're losing a quadrant of surgery, and that we basically are going to end up with conjunctival scarring, and we've lost an opportunity to do a procedure in the future. And what I've learned is that because we typically don't get flow in the subconjunctival space, we aren't getting the scarring that we are accustomed to with traditional trabeculectomy. So indeed, we really haven't lost that quadrant. And, it's just giving us another option that is much less invasive. And study after study is showing it's a safer procedure. So it doesn't have that ease or simplicity of laser trabeculoplasty, but it also has better efficacy in terms of getting your pressures down to where you need to be. And I think David did a nice job of outlining the issues that we have with ocular surface disease. And for those of us who have been using lots of these drops, they certainly make the conjunctiva a little bit more inflamed, even the prostaglandins, where we're not using them that often, maybe just once a day. But I have not seen good things happen to the conjunctiva or to the meibomian glands and the eyelids from the drops that we're using. So I think we need to be aware of, not only the options we have, but seeing if we can provide a better option for our patients than what we've done before.
Great, Howard. Thanks. A quick follow-up, Howard, to you, just again, because David hasn't done TRABs in private practice, but how has CP affected the flow through your office? And what I mean by that is, do you see less amount of time being taken up by your CP patients as far as chair time?
Well, certainly if you have a procedure which has a more predictable postoperative course, you're going to be seeing the people less. But you still need to see them, because the postoperative course is just going to be a little bit different, even though we don't have the major complications that we do with a trabeculectomy. They still need to be watched carefully. And what's interesting, I spend maybe a little less time with the patient from the chair aspect and more conversation with the patient and the family with how pleased they are with the results of the procedure. And it's surprising how many people are now aware of what a bleb means. 5 or 10 years ago, patients didn't even understand that. Now patients are coming in and seem to be more keenly aware of the downside of having this thing called a bleb or a bleep, or how many different ways all this have heard patients describe it. So it's nice having that conversation about why you did the procedure, and the patients are actually much more engaged with it than they were before.
Great, thanks. Hey, David, I've heard you say, I know a lot of doctors hear that, that this is a difficult procedure to do, et cetera, and their first thought in their mind is, can I learn to do this? And I've heard you made the analogy, if you've learned phaco, you can learn CP. Could you elaborate on that a little bit?
Oh, I definitely think that's the case. Many of us at this point in our career, pretty much any point after residency, view phaco emulsification as something that's just fun and relatively straightforward. But phaco emulsification, despite what the press may say, a recent Wall Street Journal article that got many of us particularly irked when they compared the value of phaco to the value of a single visit with an internist. Anyway, the idea that it can be done in 15 minutes, so therefore it's easy to do. That's like saying that someone who can make 23-point baskets in a row, none of us think that these pro basketball players, what they make look easy is actually easy. We know it's not, but somehow, many of us have even kind of fallen into that lazy sense that, phaco emulsification is pretty straightforward, but it's really not. It's a very, very delicate surgery. And, we all know what can go wrong. It goes wrong less with experience. But when you're dealing with a structure as delicate as the capsular bag, you've got the skill sets that are necessary for dealing with the, dissection along Decime's membrane. Now, granted, you're dissecting along the membrane with a sharp instrument rather than we usually try to use blunt instruments around the capsular bag. But the skills necessary are very, very similar. It took many of us much, much longer to learn phaco emulsification than it will with the skills that we now have to learn canaloplasty. It's a new, certainly there are, new elements about it that we may not all be familiar with. But, for me, having done no actual scleral surgery for a decade, I found that it was something that was, very, it was new, but I did not find it to be challenging in a sense of scary difficult. It was just learning the anatomy around the canal, which was new for me. Getting a sense of how thick I could cut sclera, and how thick the flap had to be, and just a number of things that you get a sense for. But for me, the issue really was I don't mind something that's surgically challenging. What I didn't want is the unpredictability of the postoperative course. Howard already mentioned that the postoperative time spent, it may not be as little as with phaco emulsification alone, but the difference is that for the most part, the visits are relatively predictable in a way that's much more similar to phaco emulsification post-ops than trabeculectomy post-ops. And also, like phaco emulsification, once you've gotten out into out past the first couple of weeks, the conversation really turns around, how thankful the patients are, and it's just it's a very, very different experience. So the challenge is a surgical challenge rather than a post-surgical challenge, but it's a challenge that I think most cataract surgeons can easily overcome.
Okay, thanks, Dave. You both mentioned, and if you both want to comment on this, that'd be great, but the quality of life improvement that you see in your patients, I think through both of your experiences, your data has mimicked our clinical study that shows that we get patients off of most, if not all, their drops. How has that been accepted by the patients? Because as we all know, patients don't like drops. They're a hassle to take. They irritate their eyes. They have to remember to take them. Compliance is an issue, et cetera, et cetera. How has that worked out for your patients that you've done canaloplasty on? Are they pretty pleased to be off those medications?
David, do you want to start off?
Sure. I've actually found that is one of the main reasons that I am performing canaloplasty. Many of my patients are not, in-stage severe glaucoma patients who absolutely must go on to glaucoma surgery. Of my first dozen, 3 of them were pure lifestyle issues. One was a long-distance biker who was on a prostaglandin analog and was very concerned that prostaglandin analog was being degraded in 100-degree weather as his bag was shipped forward and then left on a hot asphalt pavement during the day. And he was also just concerned about the possibility that if he did go on to have surgery, he, as Howard mentioned, it was aware of the issue of a bleb and was concerned about that with his active lifestyle. Another patient that I had, busy professional baby boomer, lots of travel, and just knew that drops were not going to fit into his lifestyle. So we went straight to argon laser trabeculoplasty. He didn't respond to that. And then he said, well, what's next? And so he actually went straight to canaloplasty in a much more European approach. But, he was well-informed and recognized that he just was not going to be able to use drops with the lifestyle restrictions he had. And then a number of patients just with severe dry eye, had a couple with filamentary keratopathy, which really brings up the whole issue of, when we say maximally tolerated medical therapy, if we're really honest with ourselves, it may be maximal therapy, but it's usually relatively intolerable to the patient. And so I really find that a number of my Southern California patients who may have controlled glaucoma on drops are so miserable with the ocular surface disease that I now have a number of patients who have gone on to canaloplasty, not so much to treat the glaucoma, but to eliminate the problems that the topical glaucoma treatment has caused. So yes, I think that lifestyle is a very important issue with regard to, the option of canaloplasty. But I think it's also one that we just really need to consider more when we're treating our glaucoma patients. That yes, we are trying to save their vision, but many times I do think that we negatively impact the quality of their lives with maximally tolerated medical therapy.
Great, David. Howard, any comments?
I just want to add to what David said. There's a couple of tipping points that help us get to where we need to go. I'm in Seattle, and the Northwest, even though it's West Coast, is perhaps a little bit more of a conservative area than down in Southern California. But a couple tipping points to talk about. First of all, there are some studies, and the most important one is the SIGIT study, that says it's okay to do surgery early in the treatment course or even as primary treatment. And granted, we use trabeculectomy, but that was an important tipping point that says that surgery is a viable option to treat glaucoma, and it doesn't have to be advanced or end stage. The second is that people are more engaged, whether it's family or whether it's people being on the internet. They're asking more important questions. They're also engaged with the particular choices that they have to manage their glaucoma. And one of the things that isn't an issue now, but it was a couple of years ago when I got involved with canaloplasty, is that it really wasn't covered by insurance. So at the time, we had to have people sign an ABN, Advanced Beneficiary Notice, and have them pay cash up front. And this was something that, as a glaucoma specialist, did not come particularly easy. But with experience and understanding what they wanted and what this procedure would offer, it became easy and easier to the point where people became engaged and they want to have this procedure even if they have to pay out of pocket. So there's been a change in the knowledge base. And then finally, we have to deal with a certain reality that we're going to be evaluated not only by our skill set, but also how happy we make our patients. And people don't really talk about that, certainly within glaucoma. But having as many options out there to help our patients, I think is something which is really going to be imperative for all of us to consider. And obviously, for those of you on this conference call, you're obviously dialed into this because you're interested in offering canaloplasty to your patients. So just a couple points that kind of work very well and dovetail with what David said.
Great, thanks. I've got a few other questions here that people wrote in that wanted to have asked, but before I go on to those, I want to go ahead and open it up for questions from people that are on the phone to make sure that we get everything covered. So if you're on the line and you have a question, all you need to do is hit #6 to unmute your line, and then you can ask your question, and feel free to direct it to either doctor that you would like to. So are there any questions out there?
Yes, I have a question.
Okay.
This is Alan Gammon in Modesto, California. I've been in practice for over 20 years and done most of the procedures. Did a trabeculectomy just a week ago, in fact. The problem with all glaucoma procedures that I've ever done is none of them work forever. What's our longest experience with canaloplasty, longest series, and what seems to be the staying power of the procedure? That's one. Second, those of you that are doing it currently, what would be the 1, 2, 3 most common complications of the procedure, particularly for the beginning learning curve?
Howard, you want to take that?
Okay, thank you. Good questions. Aren't particularly easy questions, but the second was complications, and the first was, help me out, Alan. What was the first question?
Longevity of the procedure. What's the longest that we have, and of your experience?
Well, let me share with you what's in
the longer series. How is it holding up as a solution for keeping the pressure down over time?
There now is 3-year data that's been published in peer-reviewed literature, showing that the people who respond tend to have a very consistent response with this particular procedure. There's also a couple other articles, I think, that have recently been accepted for publication that don't have the 3-year data, but compare canaloplasty to trabeculectomy. And most people feel that a year is the bare minimum you want to see to look at the efficacy of a procedure. But clearly, 2 years, 3 years, 5 years, those are the studies that give us some predictor of how things will work long term. But we do have, at least in my experience, we're in the process and we've been accepted for publication, our 1-year data, which is not particularly long in the context of 3-year data. I can share with you anecdotal cases we've done with 4-year results that are working well, but the challenge you have with the anecdotal results are, exactly that, they're anecdotal. But for the most part, we're not seeing the failures that we typically will see with trabeculectomy. So it appears as though canaloplasty, if it's working well for a patient, and I would say the majority of the time it does work well, it's holding up over time. The second question is, what are the most common complications that you have? And I think you can break down complications in terms of what happens intraoperatively and then also what happens postoperatively. And they will change as your experience kind of ripens or matures. The biggest problem that I've seen intraoperatively is that when you're making your window, what we call the trabeculodesmatic window, sometimes that will perforate. And on occasion you may get some iris prolapse. That tends to be more reflection of the initial learning curve, but it can occur, and I think that's probably one of the more challenging aspects of the procedure. And the second would be that you have a hard time passing the catheter 360 degrees. You would think finding the opening would be hard, and it really isn't. But sometimes you can get directed down a collector channel, or you'll hit some area of scar, and it's challenging to go all the way through. So those are probably the two most common complications or frustrations, and they tend to get better with more experience. Postoperatively, I think that the things that I've seen are sometimes you may have a little bit of a shallowing of a chamber, and you can develop either a little blood or a little synechia to the posterior aspect of that window. And if that happens, it's not unusual that they need a laser iridotomy and retraction iridoplasty. And again, that's a reflection of how tightly you close your flap and how meticulous you are with your dissection. And again, that tends to go away with time. And then the other complication postoperatively, if you want to call it that, is sometimes the pressure will go up, and that is either a reflection of poor flow through your window may be a little bit thick, or sometimes you'll see a steroid response. And with the steroid response, stopping these people's steroids relatively early arrests that problem, and for those that don't respond that way, doing a goniopuncture can often be helpful. But again, those particular issues become rarer and rarer when you have a little bit of experience under your belt.
Yeah, I'd like to add to what you said with regard to the long-term results. Although it's true that we don't have 5-year or longer results published for canaloplasty, there are 5-year and 7-year results out there for viscocanalostomy and phacoviscocanalostomy, which theoretically should not give us the same result that canaloplasty, should not be as good. And yet the 5-year results of viscocanalostomy, the average pressure was still hovering in the low to mid-teens on patients 5 years out on patients who had started in the mid-20s. And the 7-year phacoviscocanalostomy, which was published in the Journal of Cataract and Refractive Surgery in 2006, actually showed a sustained reduction of 30%. So those I consider to be very encouraging results for a surgery that pretty much is universally accepted as not being as effective as canaloplasty. Then with regard to my perspective on some of the intraocular and or intraoperative and postoperative issues that can come up, one of the things that I noted early on was with the recommendation to visco-inject or click once every 2 to 3 clock hours, I was getting some Descemet's detachments. Now that I'm clicking only every 3 to 4 clock hours, I really don't see the Descemet's detachments that I was early on. Also, the hyphemas don't seem to be as significant as they were when I was clicking more frequently. The postoperative pressure spike, interestingly, I've now moved to a rapid taper of Pred Forte, which is the steroid that I use, simply because I don't really see that there's a whole lot of need for Pred Forte since we're not trying to protect a bleb. And if Pred Forte is maintained, and I would expect it to be even worse with Durezol or one of the others out there, in my experience, it's almost predictable that between weeks 2 and 4 there will be an elevation in pressure. It's usually not too great, but it is an elevation. Now, one of the things that I found to be very helpful is letting my patients know beforehand, before surgery, that their pressure weeks 2 through 4 may go up, and that's okay. It's expected. If you don't let them know that, then they become really disappointed and feel that maybe the surgery failed or didn't work. And so one of the things that I would encourage with canaloplasty is really managing the expectations of your patients as to what that early postoperative course is going to be. You really don't need to manage the long-term expectations because, in general, they're pleased. They're on fewer drops, their pressure's lower, their eyes, if they were dry, are feeling better. But early on, there are some expectations that need to be managed. And, hyphema is one of them. They need to know that their vision may be blurred early on. Indeed, there's even an article that was published in Europe that suggests that having a hyphema may actually be a good thing as far as predictive of success of the surgery. Howard, you know more about the theory on that than I do.
Great, David. I hope that answered your question. Is there any other questions out there? Remember to hit #6.
Hi, can you hear me?
Yep.
Hi, this is Oat Sinchai. I'm practicing in Orange, California. I've been practicing for about 6 years, and glaucoma trained, doing mostly trabs with express shunts. So I'm trying to start out recruiting patients, and I just want to get your input in terms of how did you start the discussion with patients, not having performed the actual procedure, and getting the patients to agree to do the surgery.
Howard?
Okay. I'm thinking back how those conversations went. A big part of it is getting your arms around the new procedure, in this case, canaloplasty, so that you can understand the science behind it and understand that it is very much a very viable, very successful procedure. So in other words, what I'm suggesting is, as a surgeon, you have to believe that this is a good procedure to offer your patients. And then the next step is to understand where you want it to fit in to your treatment armamentarium. And I agree with everything that David says, but I look at this procedure as a safer, less invasive, and more predictable procedure than a trab. I also tell patients that there aren't any operations that I could offer them that I can give them a guarantee, but that I want to create as many options for them so that if one doesn't work, I haven't burned any bridges. So as I reflect on the question, I kind of use the burn the bridges approach in terms of setting up the conversation for him.
David, any?
Yeah, my approach would be very, very similar. Howard is absolutely correct. You've got to be comfortable with the procedure, and from my perspective, being completely uncomfortable with trabeculectomy, it was quite a leap to start offering canaloplasty. But some of the things that made me comfortable with offering it was one, the safety profile, as already mentioned, but the fact that the things that could really go wrong, I mean, really bad, just don't happen with canaloplasty. And maybe it's, just happened that time-wise, I just read this book called The Black Swan. Don't recommend it. It's a long book, but maybe if you can get a brief version on Books on Tape. The idea is basically when you make a decision, you want to know, not what the average result of it is going to be, but what's the absolute worst and the absolute best thing that could happen, and put that into perspective. And I thought that was really a useful way to look at TRAPS versus canaloplasty because, for example, with canaloplasty, you just are not going to see a flat anterior chamber. Do you see a hypotenuse eye? Well, sure, I've had a couple of patients who've had pressures of 0 on the first couple of days' visits. But the amazing thing is that they all have formed anterior chambers, and they resolve on their own, usually, sometimes with a little help with a bandaged soft contact lens or other things. But it's just the things that I feared don't happen. And so for someone who is considering starting any new procedure, having that comfort, knowing that you're just not going to get into extreme hot water. For me, that was very comforting. Canaloplasty is not without risk, but it's exceedingly rare for somebody to lose vision from canaloplasty. And as Howard's already mentioned, you do not burn any bridges. So if it doesn't work, you can always go on to trab or tube. So in that sense, it's really a no-harm, no-foul surgery, which is one of the things that is really easy to communicate. Once you've become comfortable yourself with it, then communicating it to the patient is easy, and they just get it. At least that's been my experience. I mean, going from 0 glaucoma surgeries to, nearing 100 now 1 year after offering canaloplasty in a general ophthalmology practice shows you just how, and I'm not at all good with sales. I mean, my refractive surgery and my conversion rate for multifocal IOLs is not at all stellar. So this is very much just a matter of, my comfort and the low risk is something that's appealing to patients with glaucoma.
Thanks, David. Any other questions out there?
What patients would you consider are contraindicated for canaloplasties?
Okay, I'll field that. I think those people, you can put them into a couple different groups. I wouldn't do this in somebody who had a very narrow angle. I think you need a relatively deep angle to do this procedure. People who have neovascular glaucoma are people that I would not consider doing. There's some thought that this may work out very well with uveitic glaucoma. And for those of us who have done trabeculectomies, uveitic glaucoma is not a good choice. But we, in the past, have done goniotomies, and they've worked relatively well. So I think uveitic glaucomas, I probably wouldn't let that be one of my first procedures, but certainly it's not a contraindication. So I would say if you have a deep angle If you have an angle that does not have any sneaky eye, and if there's no significant neovascularization in the anterior chamber, then those are your good patients. The ones who have a shallow angle with scarring, with PAS, the people who have neovascularization are the ones that I would not offer this procedure to.
Howard, how about a patient with a narrow angle who's phakic and you're planning phacocanaloplasty?
That's a good choice. I've done that. The angles still are a little shallow afterwards, but they're certainly deep enough that it's something that I offer my patients.
On that note, and perhaps this is something that might be worth discussing offline at another time, but I was just wondering, as far as the patients who you've seen, has anyone, or has it ever been reported that anyone's had an angle closure post-canaloplasty? Because, I've seen some of my post-canaloplasty patients who are phakic, and at least by OCT, some of them, when you're looking at that step-off, the area below the step-off appears narrow. But if you think about it, as far as the modified anatomy, since you're pulling or distending that trabecular meshwork, you've really got an open drainage system there, even if there's a narrow area peripherally. At least that's the impression that I get from looking at these scans.
Well, I think you can look at, maybe a different type of angle closure called aqueous misdirection, or which we used to call malignant glaucoma. And I haven't seen any reports of aqueous misdirection after doing these particular procedures. As you know, there are different types of angle closure, one of which is plateau iris, and you don't really know yet plateau unless you've done a neurodectomy. I suppose you can do it. I just have not jumped on that bandwagon.
Right. Oh no, I'm not. Certainly wouldn't advocate that somebody do it in the presence of a narrow angle. Just as far as the comfort that, if the angle is narrow and a phakic patient and you're planning a combination that, as you said, sometimes it's a little narrow, but it seems to be very safe after phacocanaloplasty.
And I agree with that. But if you have somebody who has a combined mechanism glaucoma and they need surgery, invariably there's significant sneakial closure in the angle.
Yeah.
So
certainly, I'm sure that some of those on the line are wondering, what are the good, first cases for this, and certainly an open angle without any of these other conditions would be important. Don't follow what I did with my first cataract surgery, which was in residency. I ended up with somebody who had a corneal opacity, so that was a bad first choice. And so I would say that for canaloplasty, wide open angle would be very good in a patient. I would also suggest, although that canaloplasty, I think, has some benefits in those who are highly myopic, I would definitely say that for first or early canaloplasty case, a high myope would not be on my list, just because of the the scleral anatomy. Would you agree?
Yeah, I agree. I mean, if you have a big eye and there's a chance that the sclera is going to be thinner, you can end up with kind of a surprise when you go make your first dissection. You find out you're all the way through, and we've been able to work through that, but that's a little bit of a different skill set. The other thing with the high myopes, and I'm going to give you a reason to consider doing it and a reason not to consider doing it, because there are some patients, especially those people who have weak or ectatic sclera, that when you do a procedure which forms a weakness in one part of the eye, you can induce a fair amount of astigmatism. And you can certainly do the same thing with a trabeculectomy. And so that's something that supports what David was saying. On the other hand, if you have somebody who's at risk to develop hypotony maculopathy, like your young male myope, then here's a good reason to consider a canaloplasty, even though the sclera may be a little thinner. So you really have to individualize your patients. You know, one of the questions that come up to me is, well, I'm waiting for that ideal patient. And I think the ideal patient is somebody who needs surgery. And, you know, that's the one, if they have a good deep open angle, that's the one to consider, you know, to be your first patient.
Thanks, Howard. Any other questions out there? And if you ask a question, if you could maybe tell us who you are and where you're from, so get a feel from what part of the country, that'd be great. Anybody else out there? Remember, you can hit #6. If not, one other thing I'd like to bring up, Howard and David, you know, somebody did bring up, you know, those perfect first patients, and I think as we've all discussed, you know, the best patients are those patients with open angle on multiple meds, going to phaco and you know, wanting to get off meds. I mean, there's a wide gamut of patients that this procedure can benefit, and I think sometimes the doctors going into it just tunnel vision a little bit too much in trying to select that appropriate patient, and then get a little bit behind the curve on getting the number of procedures out there to get through the learning curve. What are your guys' thoughts on that, based on some discussions with others that have taken over the procedure?
Go ahead, Dave.
You know, for me, I was actually surprised how I was actually surprised at how many potential patients I had in my practice once I actually started looking at the comorbidities that my glaucoma patients had. And again, this is an arid environment here in Southern California, but you know, all of my patients who were on 2 or 3 drops had significant ocular difficulties. And when I was looking at their chief complaints in the chart, that was the major thing that they were coming in, and they were just miserable with that. So for me, you know, when I you know, started calling through all of those patients, you know, any of those who were having, you know, who I was questioning, you know, are they progressing, I would start to have the discussion with them. And, you know, amazingly, I would say 50% of my combined dry eye glaucoma patients who were, you know, on maximally tolerated medical therapy, and, you know, I was concerned about are they really well controlled, just jumped at it and said, if you can do something that will help me with this chronic irritation and redness and discomfort, and treat my glaucoma, you know, I'm in. So it really, it turned out not to be a very difficult choice. Once I looked at it from a perspective that was granted a little out of the box, I wasn't looking at it strictly as, oh, here's somebody who's progressing in glaucoma and they're on all their drops and they're going to need a trab, and you know, should they have a trab or should they have canaloplasty? I was really looking at them from a more holistic point of view of treating the patient and his or her, you know, entire ocular condition.
Great, David. Appreciate that. One last chance for any further questions. Any more out there?
Yes, this is Alan Gammon again, Modesto. David, Howard, what one best go-to graphic animation, real-life surgery, high-definition surgery, YouTube material should we go to for those of us that have not done this to review it?
Oh, that's easy. Dr. Barnebey's video. This is relatively new. You put that up a few months ago?
I'm not sure when it showed up, but...
Okay. It's on YouTube, and I found it very useful.
Well, thank you.
Yes. I've been working on one myself, but it's just, finding the time to edit video one of these days.
Yeah,
I would definitely recommend that.
Yeah, let me answer that question.
I kind of give a pearl, Rick.
Oh, sure.
One of the things that I would suggest for those of you who are really serious about doing this and really serious about being successful is you need to put the time in. You need to put the time beforehand. You need to trust that this procedure is good. And you need a certain volume if you're going to be successful. You can't do a case here and a case there. You really need to dive in, with both feet. And so to that point, I think you need to look at this as a procedure which will help the majority of your patients who need surgery, and the ones you can't do are the exceptions. But if you're going to be successful and you're asking for a pearl, you need to have 100% commitment, and you really need to have a certain volume. It doesn't mean every time you do it, you do 3 cases every week, but you need to have that consistency of doing it week in, week out.
I would agree with that. I'd say that you really do have to commit. One of the things that struck me early on is when Adam and I first talked about that. He said, if you're going to do this, you've got to commit to 10 cases. And there's no upfront financial investment in terms of committing to purchasing 10 catheters or anything. It was just he wanted to know that I was mentally ready to commit to the first 10 cases. And I do think that that's important because canaloplasty, although it does not have the significant vision-threatening complications that other glaucoma surgeries have or are maybe rare but still more frequent than with canaloplasty, there's no question that because it's a new procedure and it's a delicate dissection, that the first few cases you're going to encounter, some of these complications. And the wonderful thing about encountering them early is that when you're in those first dozen, the support that you get from iScience is just unlike the support that I've experienced from any other surgical company. I mean, you've got a list of doctors that you can call, including I'm always available. Dr. Barnebey has been very available for me when I've had questions. The clinical specialists are there. So, it's good to actually encounter these complications early on for 2 reasons. One is, you've got the support. And 2 is you learn that these things resolve. The complications, you see that most of them take care of themselves or can be taken care of relatively easily, and the patients end up doing very, very well. But if you're not committed to, at least getting through those first dozen, then it's easy to get, kind of skittish because it's a new procedure and you're going to encounter, one or multiple of these complications. My first patient, the one who was on 10 drops, I encountered 3. She had a large hyphema, a decimated detachment, and induced astigmatism. But after after getting through that, she ended up with a pressure of 10 off all of her drops, happy as could be, and couldn't wait for her other eye to be done. So, it's important to make that commitment. And once you're confident, you'll really be doing your patients a great service.
Thanks, David. Thanks, Howard. Regarding the question the doctor had on videos, please feel free to contact your local iScience business representative, and they can guide you to a lot of different videos that are out on various different sites, and many of them that are very excellent. Howard's is one. Dr. Michael Morgan has an excellent one out there as well, and there are others. So if there are no further questions, I'd like to thank everyone for their time. And if there's anything else we can do for you as a company on your path to adding canaloplasty to your surgical offering, please don't hesitate to give us a call. Contact your local rep, and as the doctors have indicated, they're pretty open to speaking with you one-on-one as well. So Appreciate your time. Everyone have a good night. Thanks, Howard, and thanks, David, for taking time out of your busy schedules. And we'll talk to you all soon.
Pleasure.
Thank you.
Night.
All right. Good night.
Good night.